Hello, Dr. Paulina Weeder and our fellow colleagues. My name is Kritika and we are Group 2G. This presentation will be conducted by myself, Daniela, Jeffin, Angel and Hisham. And today we are going to be discussing the presentation, differential diagnosis and management plan for our patient. Mr. DC is a 72-year-old man. He presented with a complaint of ulcers, which has lasted for 5 months, alongside bleeding of the gums and with corrugated nails, which he has taken nothing for. I will now discuss the medical, dental and social history for the patient. Mr. DC's medical history presents with 3 medications, hypertension and a previous colonoscopy having been done. The first medication is Cresta, which is a statin used for reducing cholesterol. Cresta is linked with side effects, but those most relevant to our patient include dry mouth, fruity odour, nausea and stomach ulcers. In relation to his hypertension, he takes 2 medications. The first is atenolol, a beta blocker which causes gastrointestinal upset and xerostomia. Xerostomia could be further linked to caries, difficulty in mastication, dyschezia, dysphagia, candidiasis, and can cause oral lichenoid reactions. Norvax is the calcium channel blocker used for hypertension management and is known to cause gastrointestinal upset, xerostomia, and drug-induced gingival hyperplasia. He has listed that he's previously had a colonoscopy and has corrugated nails. Looking at Mr. DC's medical history and before proceeding to further inquire about why a colonoscopy was undertaken, we can form a potential link between all 3 medications as they tend to upset the gastrointestinal tract alongside corrugated nails. Moving on to his dental and social history, we would further investigate any previous dental treatment he had received, his diet and the frequency of eating, oral hygiene practices and if he wears any dentures. We would inquire about smoking habits as it may mask periodontal health and about alcohol intake as these could be potential risk factors for some differential diagnoses. Furthermore, we would conduct a PSR score, do periodontal charting and mobility testing. Hisham will now be presenting notes on the extra and intraoral examination.
Thanks, Kritika. In the clinical examination, Mr. DC did not present with any obvious weight loss, jaundice, anemia, cyanosis, finger clubbing, ankle or media, or skin lesions. In an extraoral examination, generally skeletal relationships of the face are established, muscles of mastication are palpated, the TMJ is checked for clicking, pain or deviation, lymph nodes are palpated, and the symmetry of face is checked. Skin and lymph lesions alongside visible swelling are also checked. No abnormalities were detected. For the intraoral examination, the clinical photograph reveals the gingiva as hyperplastic and appears to be coral pink in color and edematous. There is also plaque and calculus buildup around the cervical region of the tooth, possibly indicating a poor oral health status. The 1-1 may have been recently extracted as the sockets haven't fully healed. There is limited view of the buccal mucosa, palate, floor of the mouth, so it would be ideal to check for other pathologies in a further examination. Regarding the occlusal assessment, the occlusal relationship of the incisors are class 1. Molars cannot be determined from the picture provided. The restorations in the mouth made upper metal is possibly amalgam. The non-carious tooth loss on the lower teres, possibly due to bruxism or trauma. Presence of posterior crossbite and collapsed dentition is also observable. In the OPG, the condyles are symmetrical and the body of the mandible appears normal. In the ramus, there are spherical radial opacities on the left-hand side. No abnormalities were detected in both the left and right sinus. There is generalized maxillary horizontal bone loss with severe angular bone loss at the 2-6 mesial. There's also mandibular furcation involvement around the 3-6 and 4-6 for lateral lucency at the periapical region of the 3-6 mesially. The teeth present are the 1-6, 1-3, 1-2, 2-1, 2-6, 2-7, 3-7, 3-6, 3-4, 3-3, 3-2, 3-1, 4-1, 4-2, 4-3, 4-4, 4-6, and 4-7. There's also defective restorations present in the dentition of the patient. There's also root canal treatment on the 1-2 and 2-2. There's presence of caries, 1-3 mesily, 1-2 mesily, 2-6 distal occlusal, and 3-6 buccal. There are also edentulous areas in the mouth. There's a presence of a root fragment for the 2-6. Angel will now introduce the differential diagnosis.
Thanks, Hashan. These are the list of differential diagnoses for our case. I will be presenting gingival hyperplasia and leukoplakia. Jeffin will do moderate to severe periodontitis and phodiaces granules. Hashan will be doing frictional keratosis. Daniela will be presenting oral squamous cell carcinoma. And lastly, Kritika will do Crohn's disease. So in relation to the conditions associated with the gingiva, the first differential diagnosis is drug-induced hyperplasia. Calcium channel blockers have been associated with the induction of drug-induced gingival hyperplasia in patients with long-term use. This is a benign condition characterized by an increase in gingival mass and volume, which may range from mild to severe. Clinically, there is an increased bulk of free and attached gingiva, especially around the interdental papillae, which we can see in Mr. DC. There is also a loss of stippling of the gingiva, as well as the gingival margin becoming rolled and blunted. Drug-induced gingival hyperplasia occurs in a range of colors depending on the severity of the inflammatory response. This includes reds to blues to lighter coloring than the surrounding tissue, of which the latter is seen in Mr. DC. The condition also does not impact on edentulous areas, which we can also see in the case photograph as well as the radiograph. The hyperplasia can be localized and generalized, and is known to be more pronounced in the anterior teeth and the facial and buccal areas, rather than the posterior teeth or palatal or lingual areas. Drug-induced gingival hyperplasia can have a typical presentation of fibrous and firm gingiva, which we can see in the patient, but there may also be signs of non-inflamed gingiva, edema, erythema, and bleeding. From those, we can see edema, and gingival bleeding was a presenting complaint for the patient. As the tissues increase in mass, it can create pockets that harbor large quantities of bacteria, which can be difficult to clean and access, thus leading to increased incidence of caries and periodontal disease, which we can see in the patient's radiograph. The presentations of the condition that we cannot see in Mr. DC is the lack of gingival extension coronally, where the crowns are not covered by hypoplastic tissue. The interdental papillae also does not have a lobulated appearance in the patient. We do not know if the signs of the drug-induced gingival hyperplasia can be seen in 1 to 3 months after initial dose, which is typical for this condition. Thus, this may be a further question asked to the patient. Histologically, drug-induced gingival hyperplasia cannot be clearly distinguished from other forms of gingival enlargements. However, we may see gross fibrous proliferation, seen as red in the picture. Treatment and management involves the cessation of the offending medication or substitution with another class of drugs entirely by the patient's GP. The medication could be changed to beta blockers, diuretics, or ACE inhibitors. Of course, this may not always be possible. In that case, substitution with another calcium channel blocker, which has lower risk of inducing gingival enlargement, can be considered, such as varampril and isradipine. Furthermore, non-surgical periodontal treatment may be carried out involving the removal of plaque and calculus through scaling and root planning. This has been shown to reduce the enlargement by reducing or eliminating the inflammatory component. Antimicrobial rinse, such as chlorhexidine mouthwash, can also be used for management, where the primary aim is to reduce the overgrowth to acceptable levels, thereby eliminating the need for surgical treatment. Surgical periodontal treatment, such as gingivectomy, gingivoplasty, and flap surgery, may be performed in conjunction with prophylaxis, oral hygiene instruction, and comprehensive home care program. I will now pass on to Jeffin, who will talk about periodontitis.
Thanks, Angel. Periodontitis is an inflammation of the tissue surrounding teeth that results in attachment loss and destruction of alveolar bone. We believe Mr. DC may have generalized chronic periodontitis since the periodontitis affects more than 30% of the mouth. We would like to ask if Mr. DC smokes, since smoking can aggravate periodontal disease, as Kritika mentioned previously. In relation to the etiology, dental plaque can induce chronic periodontitis by release of lipopolysaccharides and other toxins, which initiates host response. If the biofilm is undisturbed for a long period and the patient is genetically susceptible to periodontitis, alveolar bone gets resorbed by the inflammatory mediators to be infiltrated with inflammatory cells. For the clinical presentation, pocket depths of 3 to 4 millimeters of clinical attachment loss, or CAL, whilst probing is indicative of moderate periodontitis, whereas 5 millimeters or greater CAL is indicative of severe periodontitis. In the next appointment, Mr. DC's CAL must be calculated to see whether he has moderate or severe periodontitis. Bleeding on probing, or BOP, might occur. However, if Mr. DC smokes, there might be no BOP and decreased inflammatory response. This may suggest why Mr. DC does not have erythema on his gingiva. Management of periodontitis includes removal of plaque and calculus by a thorough debridement. Oral hygiene instructions should be implemented
Smoking cessation advice could be given if Mr. DC smokes. Periodontitis associated with diabetes or HIV infection should be appropriately managed if he has such systemic conditions. Now we will move on to white lesions. I will be starting off with a discussion on fordyces spots. Fordyces spots or granules are ectopic sebaceous glands that occur on the oral mucosa. There are reports that it is common up to 80% of the general population and that their presence must be considered a normal anatomic variation. We believe Mr. DC may have fordyces spots. It is thought that genetics play an etiological part in the formation of fordyces granules. Similarly, there are also studies that link fordyces spots to idiopathic etiology, and they are known to be associated without any disease or illness. One study links fordyces spots to a hereditary non-polyposis colorectal cancer syndrome. This may indicate why Mr. DC had a colonoscopy in the past. Fordyces granules appear as multiple yellow or white asymptomatic papillary lesions of 1 to 3 mm in diameter. This is present with Mr. DC. They commonly occur on the buccal mucosa and the lateral aspect of the vermilion of the upper lip. They may also appear in the retromolar area and anterior tonsillar pillar. In relation to a patient, these fordyces spots appear on the gingiva. A study found out that there is a 0.76% chance for these lesions to appear on the gingiva. They are more common in adults than in children, which may indicate the role of hormonal factors in this condition. Histologically, fordyces granules are like normal sebaceous glands found on the skin, except for the lack of hair follicles. Beneath the epithelial surface, acinar lobules can be seen with central ducts. The sebaceous cells in these lobules are polygonal in shape that contain nuclei, which is centrally located. For the treatment of fordyces granules, since it represents a normal anatomic variation and are asymptomatic, no treatment is indicated. Sometimes fordyces granules may become hyperplastic or may form keratin-filled pseudocysts, and the likelihood of tumors associated with these granules are rare. In such circumstances, an incisional biopsy might be necessary and a referral to an oral medicine specialist is warranted. Hashan will now be presenting frictional keratosis.
Thanks, Jeffin. Frictional keratosis is the hyperkeratinization of the epithelium in response to the stimulus excessive friction of the mucosa, such as excessive brushing, irritation of gingiva. It can be seen as white patches on the mucosa. In the early stages, though, the patches are pale and translucent, but later they can become dense and white, sometimes with a rough surface. Treatment involves removal of the stimulus, which causes the patch to disappear. The patient can be asked whether they brush hard or use a hard bristled toothbrush, and their brushing technique, which may be a reason for any frictional irritation on the gingiva. Frictional keratosis is benign, and the patient should be told that it has no carcinogenic potential.
Angel will now discuss leukoplakia.
Thanks, Hashan. Leukoplakia is an asymptomatic white patch which cannot be wiped off and cannot be characterized as any other disease. Leukoplakia is more prevalent in middle-aged to older male populations. The cause is idiopathic. However, common risk factors include tobacco and alcohol use and nutrition. Today, I'll be discussing proliferative verrucous leukoplakia of the gingiva and nodular leukoplakia. Leukoplakia of the gingiva varies in appearance from a grayish-white, flattened, scaly lesion to a thick, irregularly shaped keratinous plaque. Evidence of this condition on Mr. DC may be seen around the buccal marginal gingiva of the 3-3 and the 3-7. As a hyperkeratinized band of tissue. The area should be assessed to see whether the lesions are non-scrapable, and the oral hygiene of the patient should be evaluated. If these further investigations are negative, the area would need to be biopsied further to identify evidence of dysplasia or atypical epithelial changes. There may also be signs of nodular leukoplakia. These are normally small, polypoid outgrowths, rounded, predominantly white excrescences, which we can see. However, the typical vague whiteness is not present. It is more a white-pink tinge to the nodular regions. The site of occurrence also is atypical, as nodular leukoplakia normally occurs on the buccal commissure. Histologically, proliferative verrucous leukoplakia starts as hyperkeratosis without dysplasia, with slight to well-developed verruciform profile. It can take months for a lesion to be atypical histologically. The main management would be to refer for a biopsy. A referral to an oral med specialist is also recommended if suspicious changes occur. Daniela will be talking about oral squamous cell carcinoma.
Thanks, Angel. Squamous cell carcinoma, or SCC, is an invasive epithelial neoplasm with variable degrees of squamous differentiation and can occur with or without keratinization. SCC can occur anywhere that there are squamous cells in the mouth, but most commonly occurs on the tongue and floor of the mouth. SCC has been shown to be commonly preceded by precancerous lesions such as leukoplakias or verrucous leukoplakias. Extrinsic risk factors for squamous cell carcinoma include smoking and alcohol use. However, the link between alcohol use and OSCC is not as strong as that of smoking. Intrinsic factors include iron deficiencies, malnutrition, and an increased age. As it was not stated if Mr. DC is a smoker, we cannot say if he has a higher risk of having SCC. However, the staining on his teeth and the milky appearance of his gingiva might suggest tobacco use, putting him at a higher risk of having SCC. Furthermore, Mr. DC is an older gentleman at 72 years old, which can also increase his risk of developing SCC. Additionally, we know that he has no iron deficiency, but cannot say whether he is malnourished otherwise. Oral squamous cell carcinoma can have a varied clinical appearance. Different classifications for the various appearances have been proposed. One such proposal bases the classifications on clinical growth patterns assessed via close inspection and digital palpation. This divided oral cancer into 3 different types of growth patterns: superficial, exophytic, and endophytic. These are then further classified into observational findings: leukoplakic or erythroplakic lesions lacking deep indurations, granular or papillary lesions with moderately deep indurations, and indurative or ulcerative lesions with extensive deep indurations. Mr. DC's radiograph shows areas of radiolucency on the alveolar ridge, which may be due to bone loss. However, they do not display a moth-like pattern, making the diagnosis of the endophytic type lesion less likely. Around the area of the 2-1 and 2-6, there are radiolucencies, which may be similar in appearance to the pressure-like bone loss caused by exophytic growth patterns. Mr. DC may also have no bone loss and have a superficial growth pattern with a leukoplakic observational finding of oral squamous cell carcinoma on his buccal mucosa. However, the image quality is poor in this area, so it is difficult to properly observe the appearance of this white lesion. His gingiva, which appears to have ulcerated lesions, may also be displaying malignant potential or malignancy and could be a form of papillary oral squamous cell carcinoma, images of which can be seen on the slide. It should be noted that ulceration of the oral mucosa lasting greater than 3 weeks is of concern due to possible malignancy, and Mr. DC has complained of ulceration for 5 months. Some oral SCCs have also been found to bleed easily when traumatized. This should be noted as Mr. DC presented complaining of bleeding along with ulceration. OSCC of the gingiva can often cause mobile teeth and symptoms that mimic periodontitis, so investigation should be undertaken concerning tooth mobility in the areas displaying ulceration. Oral SCC is usually painless at an early stage but may become painful at a later stage. The patient's history of pain is unknown. Management of oral squamous cell carcinomas consists primarily of either surgery or radiotherapy, or a combination of both. Some patients may also receive chemotherapy prior, during, or after treatment with radiotherapy. Kritika will discuss Crohn's disease.
Thanks, Daniela. Crohn's disease was another differential diagnosis we had. Crohn's disease is an inflammatory bowel disease which presents with oral manifestations consequently. Its etiology is unclear, however, numerous studies suggest a genetic and environmental factorial role. Additionally, smoking, those below the age of 30, and a compromised immune system are risk factors. The oral presentations found within our patient's mouth that are linked to signs of Crohn's include edematous hypoplastic enlargement of the gingiva involving attached gingiva and extending up to the mucogingival line with ulcerations present, alongside bleeding gums. Ulcers can flare up to 2 to 8 times a year, and our patient has had recurrent ulcers for 5 months. The gingiva is pink, however it is unknown whether it is firm and painless to palpation until palpated. Diarrhea and abdominal pain are common consequences of Crohn's and could add to why he required a colonoscopy. Furthermore, Crohn's causes malabsorption, which consequently could be a reason for corrugated nails. Linear nodular diffuse mucosal thickening occurring on the labial and buccal mucosa and mucobuccal folds is another presentation common to those with Crohn's. However, it cannot be seen in the clinical photo provided, so it's unknown. Furthermore, in those with Crohn's, there are skin and lip lesions which present dually, whereas our patient presented with nil skin and lip abnormalities upon clinical examination. Angular cheilitis and persistent lymphadenopathy are common signs which aren't presented, whilst the presence of mucosal tags is unknown. Those with Crohn's tend to lose weight, and our patient doesn't have any obvious weight loss recorded, and it is unknown whether diarrhea and abdominal pain are presenting symptoms. Malabsorption usually leads to iron and vitamin deficiencies, which causes oral lesions. However, our patient doesn't have anemia according to the medical history. The extraoral exam presented with no obvious facial and labial swelling, which again is a common clinical presentation of Crohn's. Management of the patient with this differential diagnosis may include topical corticosteroid therapy or intralesional corticosteroid injections for some oral ulcerating lesions. Treatment would include upholding a healthy diet, exercise, and staying hydrated alongside good oral hygiene practice. A referral to an oral medical specialist and gastroenterologist may be necessary for correcting any deficiencies. Jeffin will now go through the special tests and investigations to differentiate between the list of differential diagnoses.
Thanks, Kritika. Special tests and investigations are mandatory to distinguish between the list of differential diagnoses. Along with the thorough history taking and clinical examination, special tests and investigations such as radiography, biopsy examination, and blood tests may be required to reach a definitive diagnosis. Full mouth photographs would be ideal since we cannot see the ulcers in the clinical photograph. Photographs are useful to see if other oral lesions are present and also to monitor progression. A periapical radiograph of tooth 3-6 would be needed to see the radiopacity periapically, furcation involvement, and the state of the pulp chamber. Percussion and pulp sensibility tests for tooth 3-6 could be conducted to see if there is pain associated with the radiopacities. Angel will now discuss special tests for drug-induced hyperplasia and leukoplakia.
Thanks, Jeffin. Drug-induced gingival hyperplasia is usually diagnosed by a thorough assessment of the medications Mr. DC takes. An incisional biopsy may reveal histologic changes. In the biopsy, we can see a high vascular connective tissue along with an influx of inflammatory cells. The overlying epithelium may appear irregular and/or multilayered. Acanthosis and parakeratosis have also been observed. Complete blood count could be indicated to rule out leukemia, which may also cause hyperplasia of the gingiva. Further testing can be carried out to confirm if Mr. DC has leukoplakia. Multiple incisional or punch biopsies of such lesions will show either hyperkeratosis, dysplasia, carcinoma in situ, or invasive oral squamous cell carcinoma. The hyperkeratosis could be accompanied with or without dysplasia. An increase in nuclear to cytoplasm ratio, cellular pleomorphism, and increased number of abnormal mitotic figures may be apparent with dysplasia. Danny will now discuss special tests for oral squamous cell carcinoma.
Thanks, Angel. Gingival squamous cell carcinoma can be easily misdiagnosed as one of the many inflammatory lesions of the periodontum. It is recommended that suspicious lesions which are unresponsive to conventional therapy should be biopsied, regardless of their anatomical region. All causative factors should be investigated and removed, and the suspected lesion should be checked again within 14 days to detect if it has subsided. For this purpose, high-quality images should be taken of areas of interest so that comparisons can be made. If the lesion subsides within the 2 weeks, no further action concerning OSCC is required. However, if Mr. DC returns with the ulceration or white lesion, a wedge resection biopsy of the suspected cancer tissue together with adjacent non-cancerous mucosa should be performed. This will be studied for dysplastic or neoplastic changes. Histopathologically, OSCC is characterized by invasion of malignant squamous epithelial cells. This invasion is represented by an irregular extension of lesional epithelium through the basement membrane and into subepithelial connective tissue. This biopsy can reveal the degree of malignancy, invasion, and probability of metastasis. Further imaging can be done to assess tissue invasion and bone resorption patterns using pantomography, CT, MRI, ultrasonography, and PET scans. Jeffin will now discuss special tests for frictional keratosis.
Thanks, Danny. Frictional keratosis will be diagnosed clinically and based on history taking. This may have similar histological appearance to leukoplakia if it were to be biopsied through incisional biopsy, which includes hyperkeratosis that is evidently caused by friction through denture if Mr. DC wears one. Kritika will now finish off the special tests discussion.
Thanks, Jeffin. An incisional biopsy and further examination is required to rule out or confirm Crohn's. A colonoscopy may be done with those with Crohn's, which was conducted by Mr. DC. Now Hashan will conclude our presentation.
Thanks, Kritika. In conclusion, the management of Mr. DC would include a comprehensive examination to address his presenting complaint of mouth ulcers and bleeding from his gingiva. The differential diagnoses From the provided information are drug-induced gingival hyperplasia, moderate or severe periodontitis, phodiasis spots, frictional keratosis, leukoplakia, OSTC, and Crohn's related to oral lesions. However, further investigations such as biopsy, blood testing, and radiographs are required to arrive at a definitive diagnosis. In the treatment of all these different diagnoses, the systemic and acute phases of treatment remains the same. Systemic management of Mr. DC includes hypertension control. If the ulcers are symptomatic, topical analgesics might be needed in the acute phase. Disease control will depend on the differential diagnosis attained and may involve liaising with the medical GP of Mr. DC in relation to changing drugs that may cause hyperplasia, referring to an oral medical specialist if the lesion was found to be malignant, OHI, and the environment. A review visit in 2 weeks to monitor lesion progression would be conducted to see if the lesions would heal by themselves. In the definitive phase, night guard would be helpful if he is a bruxist, and replacement of missing teeth could be discussed. In the maintenance phase, free monthly recall is needed since he has a high risk of caries and periodontal disease. Thank you for listening.